I think we're ready to
Yeah.
get started with our content. So if you
Oh,
want to just talk a little bit about the connection between heart and stroke, and then we'll kind of
okay.
go on with some solutions and such. But I know you've talked about this a lot, and you and I had a great conversation about it. So just
Mhm.
take it away.
Okay. Well, everyone knows probably what a stroke is, or they know someone who's had a stroke. It unfortunately is pretty common. And we always think of stroke as a brain problem, but we've now learned that that is not exactly true. A lot of the times you can get a clogged artery up here that clogs totally off, and that causes a stroke. And a stroke is loss of brain tissue because the artery supplying it got clogged up, either with a blood clot or with cholesterol buildup. But for some reason, it clogged up and causes a stroke. And depending on where that artery clogs up, people can have a stroke that only affects a little bit of the brain, or unfortunately, they can have a stroke that affects a large part of the brain. So there's also a fairly large portion of people, about 40% of all people who have strokes, that we can't find out what caused the stroke. So if anyone here has had a stroke, you know you were in the hospital, you had sound waves bounced off of these arteries, which are the carotid arteries, to see if there was a blockage. You probably had a CAT scan and or an MRI to your head to look at the blood vessels up there. And generally, we'll find the cause of stroke and we'll say, oh, you had this or that. Well, sometimes we can't find the cause of the stroke. And that is another big word,
I like
Marylee. That's called, yeah, here we go. That's called cryptogenic stroke. And that's a big word. And all it means is we can't find the cause of your stroke. And we really want to. So then we start looking at the heart to see if the heart was involved with the stroke. Now, how can that be, you ask?
how can that
And
be?
actually, good job, good job. She was a little slow on
I
the
know.
uptake there, folks, don't you think? So what we look at is the heart rhythm. It's really all about an abnormal heart rhythm. And this particular heart rhythm comes and goes. It may last for 5 minutes. It may last for 5 hours, 5 months, 5 years, forever. And that rhythm, if you watch any TV at all, you've heard about AFib. Okay. Now, what is AFib? This is how I teach my patients every single day. All right. Let me go back here. All right. You've got 4 chambers of the heart, but actually I've only got 2 hands. So we're just going to have to go with 2. You've got top chambers and bottom chambers. Okay. Normally, the top chamber contracts and the bottom chamber contracts in a very coordinated motion like this. Top, bottom, top, bottom, top, bottom, top, bottom. That's how it's supposed to work. Now with atrial fibrillation or AFib, that top part of the heart, which is called the atria, it just quivers like a bowl of jello. And then the bottom part contracts. Now, when that heart is quivering like a bowl of jello, it is not contracting well. And because it's not contracting, it's just quivering, it can get a blood clot in it. And sometimes it can get a pretty good size blood clot in it. Then either part of that blood clot will break off or the heart will go back into rhythm. That top part of the heart will contract like it's supposed to. It'll go contract, move that blood clot down to the bottom part of the heart. The bottom part of the heart contracts and the blood clot goes up the carotid arteries, which are the first major takeoff. So that blood clot can go up one side, the other, both, up to the brain, sticks in a brain vessel, and causes a stroke.
So just my own personal clarification here. So that the carotid arteries are where the blood leaves the heart and goes immediately to the carotid for distribution elsewhere.
Correct.
Got it.
Correct. They're one of the first major takeoffs of that great big artery that leaves the heart. The very first little arteries are the ones that supply the heart itself with blood. But the second ones, and the ones that tend to go, that are a very direct shot, are right up the carotid arteries and into the brain.
Okay, so that brings up another question.
Okay.
So my husband's stroke was in a carotid artery, but those people that they say, we found the clot in your carotid artery. It could be from many reasons. It could be from Afib, but it could also be have nothing to do with Afib, right?
Right. Okay. It can be. So you can have. So when we think of a blockage in an artery, we tend to think of a blockage in a heart artery. That's called the coronary artery. Right. But actually, those blockages can be in the carotid arteries. They can be in the arteries that supply the kidneys. They can be in the arteries that supply the legs. Yeah. So they can really, so you can
make
have
it, and then they're moving around.
They can, so think of a pipe. Think of an old rusty pipe. So if you've ever seen an old rusty pipe, you look at the inside of it and it's all corroded. Right. That's what cholesterol buildup looks like. Yeah. Horrible image, but true, unfortunately. So then what happens if they can't find a specific blockage, like a carotid, one or the other carotid was blocked, or one of the arteries up here, we start to look at, was it an abnormal heart rhythm that caused the stroke? Okay. So we have a couple different ways we can look at that. We can do an EKG. Well, that gives us 2 seconds in time. So unless the person is in atrial fibrillation at the time, the EKG isn't going to show us anything. We can put on a monitor that you wear for 24 hours, but and that's called a Holter monitor. But unless you happen to have an episode of atrial fib during that 24 hours, we're not going to find it. We can put on a monitor that people wear for a month, and they usually don't make it a month because you put patches on and people say, oh, my skin's getting abraded. This is just really not for me. And the yield from those types of monitors is very, very low. It's only about 2 or 3%. So we have a new tool, and that tool is called the Link. Now, this is an implantable monitor that goes just beside your breastbone, just under the skin. It doesn't go anywhere else. It doesn't go in a vein, in an artery. It just goes under the skin in the chest. And if you look, this is a AAA battery. So pretty small battery. This is our Link. It is not even as big and is only about 1/4 as thick as that AAA battery. So we can put one of these in, and you actually can put it in an office setting if you want to. And it takes about 5 minutes. We just put sterile technique, slip it under the skin, and it will monitor your heart rhythm for 3 years. And if it detects something abnormal, it sends a message to the physician's office, and their little message comes up on the computer. You have to look at this Link report. Here's an alert. And we can look and find atrial fib. We can also find a bunch of other heart rhythms that you might not necessarily want, but we'll find any abnormal rhythm with this little teeny monitor. And it's so tiny that the incision that we make to put it in is only about the size of the edge of your pinky nail. It's only about 1/4 inch long. Teeny, teeny, teeny. You can hide it under a bathing suit, a bra. It makes such a tiny scar when it's done that no one ever knows you've got it in.
So there aren't any wires or anything that are connected.
Nope. No wires
it's just
at all.
Created miraculously to send.
Well, it works by Bluetooth.
Okay, it's Bluetooth.
So we give you a little home base, a little tiny monitor. You plug in by your bedside, and in the middle of the night, If there's anything abnormal, it downloads that information and sends it over to the office.
Okay.
And the nurses come in, get it in the morning when they come in.
Okay, so my husband has an ICD because of advanced heart failure, and it monitors mostly fluid. So it's similar, except his is a bigger deal, but it's similar in that we have a monitor near the bed. Hey,
correct. You have a monitor, and it transmits the data to your physician's office.
Okay,
correct.
All right.
Yep.
I'm getting it.
So the nice thing about this is it's no muss, no fuss, you don't have to wear anything that you have to, like any monitor you have to tuck in your pocket or anything. You don't have to have patches on your chest that may irritate your skin. It just it's a 5-minute implant. Although actually some of my partners, my physician colleagues, say they can put it in less than 1 minute flat. It takes me a little bit longer.
Yeah,
but,
and talk about that.
Okay.
That you have been able, nurse practitioners can now insert that. Talk a little bit about. We talked about that the other day. Talk a little bit about that.
So we noticed a kind of a glitch in our system getting patients who needed this device called a link, getting them implanted early in the afternoon. We want to watch them for just an hour before they go home, just to make sure that they're not going to bleed. A lot of patients are on some type of a blood thinner, so we just want to make sure. And then a lot of our patients down here at the hospital where I work at, they come from 2.5, 3 hours away. So we'd like to get them home before dark. So sometimes these procedures were getting done at 5 or 6 o'clock at night, and then the patient had to hang around till at least 7. And then, of course, they wanted to go home. Everyone wants to go home. So then they were getting home at 10 or 11 o'clock at night. And especially if it was cold and snowy like it was last week, we weren't thrilled with them going at all.
Sure.
So the nurse practitioners decided this is such a simple procedure. So as a nurse practitioner, there's a certain list of things that you're allowed to do, and this is one of them. One of the other very common procedures nurse practitioners do, there is a birth control method that is put under the skin in the arm, and nurse practitioners do that. So we decided we would talk with the doctor, see if they would let us take over this procedure. So we trained on exactly how to do this with sterile technique. We're all working on doing our 10 or 12 under supervision, and then we'll be able to do these in a much more timely fashion and get that patient home that same day.
Wonderful. That is wonderful.
Yes.
So what if someone is seeking some advice, and I'm asking this because of the number of people, we do our camps, and the number of people at our camps that they say, I don't know why I had a stroke. Nobody knows why I had a stroke. And I didn't understand cryptogenic stroke the first few years, but I've known about it for probably a decade now. And I learn more all the time. But so when I've been able to talk about cryptogenic stroke, there's a huge relief. Some of these people, it just makes me emotional, because these people feel like they're less than human, or that no one can figure it out. So I must have done something wrong. It must be about me. And that can be really, really sad and heart-wrenching.
And scary.
Right. So when that's mentioned, I have found, sadly, we have great medical care here in Central Illinois, but I have found, sadly, that sometimes they have just gone to a community hospital. They haven't had access to the treatment that some of us are blessed to have. Right. And they don't even see a neurologist. They see their family physician. So walk us through maybe a couple of questions to ask your doctor if you know that nobody ever figured out why you had the stroke. And then what would be the steps to at least get an assessment and know whether the link or other monitoring, if the link would available, however that would work. Can you walk us through that just a little bit? And for everybody watching, we are going to put a couple of links in the notes in the comments section for you to go to for the company that makes the link. So we'll have that in the comments. But go ahead and talk a little bit about that perplexed individual who's 40 years old and was a marathon runner.
Yep. And it's very scary. It's very scary. Now, at the hospital where I work, it is our policy. Everyone that comes in with a diagnosis of stroke sees a neurologist. Hands down, that's it. However, not everyone gets cared for by people that work in a 750-bed, big, huge hospital.
Right.
So that's the issue. So then if your doctor says, we just don't know what caused this stroke, then I think the next question would be, could I have AFib? Could AFib could have caused my stroke?
Okay. Simple
And
question.
we even have a pamphlet that is that title.
Okay.
Yes. And I do think, if I'm not mistaken, Medtronic makes that
Yes, they do.
pamphlet that says, could AFib could have caused my
Yes,
stroke?
we've provided those to some of our campers. Yes, absolutely.
Yeah. And that, because I think it's extremely scary when someone says, we don't know how this happened. That, because these days we are, we've got a lot of medical technology in our hands. We can figure out almost anything. And if you're that little bit of the population where someone says, we just don't know how that happened, then in my mind, I'm thinking, well, so how do I prevent it from happening again? What do I do? Did I do something wrong? Or, what can I do to prevent this? And so that is a very, very scary feeling. So I guess I would, number one, ask the physician or the nurse practitioner who's taking care of me, could AFib could have caused my stroke?
Could it have played into this, what happened?
Right, exactly.
Perfect.
And can I see a neurologist, or is there a cardiologist who might be able to help me get a rhythm evaluation?
Okay.
So that's how I would start.
Okay, rhythm evaluate. That's great. Okay.
Right. Rhythm evaluation. Yep. Because this is when we started the link, and I guess I should tell everyone who's listening that this little link is spelled LINQ. And when Marylee was talking about, we're going to put a link up, she's talking about an actual LINK link.
Not an LINQ. You're right.
Right. Not an LINQ link. So we're going to, so I would ask and see if they can, if they wouldn't mind referring you, or seeing if there's someone else that you can see.
Okay. Yeah, that's good. That's good. And I mean, that's one of the things that I want to make sure people know is the questions to ask and who to reach out to.
Right.
And it may, for the people, we see some rural folks. So the people that are rural, it may require a day trip, 2.5 hours to a facility that can accommodate, but to have the answers and to have the peace of mind and the clarity is, I think, so hugely important.
I agree. Absolutely.
Yeah.
We should at least be able to, if they can't figure out the cause of the stroke in the hospital, we should be able to work on it on an outpatient basis. And I think it's extremely cumbersome to have to go through a monitor that you put on your chest and not find anything on that monitor. I think it's much easier for the patient, especially if they live hours away, to go right to having a link implanted. But that'll be your insurance company's decision. That's not, unfortunately, our decision.
I think everyone watching that's been in the hospital knows that the insurance company has a little bit. I had a random question. What was it? Oh gosh, I hate that. Maybe it'll come back. I had a random question.
I'm sure it will. I'm sure it will.
And I'm looking, I don't see it. Whoa, here we go. I was looking to see, oh, okay, here, I have a question. Why does that mention of AFib fall on the patient and not on the doctors? Don't doctors know about AFib? And I know which reminds me of what my question, answer that, and then I'll remember my question now.
Okay. Well, so I hope that doctors know about AFib. However, the problem is if you were in AFib and then then went back to normal rhythm and that heart contracted down and the clot went down to the ventricle and then it went out. So now you're back in normal rhythm. The doctor would have no way of knowing you were in AFib. It doesn't leave any traces behind, nothing. So it's a culprit. We just don't know it's there unless we catch it on a monitor. So if we do, we're good to go. But if we don't catch it, then we really have to look for it. And when you're at a big institution, I think the people that work with it are trained to look for it. When you're a family physician in a rural community, that may not be your top priority.
So and we all have to be proactive with our health. The question that popped into my head was, if I have 2 minutes of AFib and that's it, am I ever going to know that I had that? Am I going to feel anything? Am I going to, I mean, I know when people have like really fast heart rates and it's pounding, it's 140 and they know, I mean, there's a feeling, but do people have like little episodes of AFib, or is it usually all or none? Sorry for the question.
So here's the problem with AFib. Number one, 50% of patients don't feel it at all. They have no idea they're in AFib. They'll come see me in the office and I'll say, oh, you're in AFib. And they'll be, I am. The other 50% are calling me at 7 o'clock in the morning saying, okay, I'm in AFib again. My heart rate's 130. I can't breathe. What do I do? So people are either asymptomatic, or that means they have no symptoms, or they tend to have terrible symptoms, So then the other problem with AFib is sometimes it lasts 2 minutes. So by the time you even try to call and get a doctor's appointment or call the squad, it's gone. Sometimes it lasts 2 hours, 2 days, 2 weeks. There's no rhyme or reason at all.
It's kind of like the signs of stroke. There's no two alike. There's, you can't say, I mean, you can say, yes, it's likely a stroke, but it's and the outcomes. My husband has said from the very beginning that, if you look at a stroke on a continuum, we all have something along the line, but none of them are exactly the same. He can identify with most everybody's issues following a stroke, but not all of them. And I want that to be the case as well. So, well, this has been one. Any other thoughts, last minute advice or thoughts popping into your head, Kay?
So I would always say, be your own healthcare advocate. If someone says, well, we just didn't know what caused this, then say, so how do we go about finding out? I always advocate for the patient, saying, let's move on, let's figure this out. Because in my experience, if a patient tells me something's wrong, I think they're right. And I'm going to find out what's wrong with them. They'll tell me, I have these episodes where I feel terrible. They may not necessarily feel their heart racing, but they feel really short of breath. They're incredibly fatigued. And then they say, and then it goes away. Like you just turned off the oven, it just goes away. And so that tells me I have to look for something that's going on with that patient.
Okay. Fascinating. Don't see any other, does the link defect SVT, and can that be confused with AFib?
Oh, yes, the link will detect abnormal rhythms. It can be confused with AFib, but what the link does is it takes a snapshot of that heart rhythm so that we know exactly what it is seeing, and it sends this to us so we can say, oh, is that AFib or SVT? We can figure that out pretty easily. Okay,
good. That was a great question, Linda. Thank you.
Very good
question. Yes, thank you. I like it when our viewers have good questions. So,
yeah.
Well, I want to thank you, Kay, so much. And when I talked with Kay before this, she's agreed to come on again and maybe do one of our support groups